The patient is bleeding to death from a vessel deep inside the liver. No incision. No general anesthesia. A 1 millimeter catheter threads from a stick in the groin, climbs the aorta, finds the bleeding artery, and stops it with a platinum coil. On the fluoroscopy screen, the contrast blooms once and is gone. The patient is stable by sunrise. You did that. The emergency room team takes the credit for catching the bleed. The hospitalist signs the chart. The medicine team rounds on the save in the morning. Your name is nowhere in the record. You go home in the dark. Image-guided surgery for the doctor who never picks up a knife. $1 million ceiling for one of the most invisible jobs in medicine. Level 1. Medical student. 8 years ago, you took the MCAT. 2 years ago, you started your first IR rotation as a third-year medical student. 4 hours of watching a senior attending thread a microcatheter into the celiac artery to embolize a bleeding tumor. You wrote in your application essay about that procedure. Noon Eastern. The email opens on your laptop. The screen says Integrated Interventional Radiology. 6 years are now locked into a specialty most of your family will never quite name. You text your parents. Your mother doesn't recognize the words. You explain it 3 different ways. Image-guided surgery without a big incision. A 1 millimeter catheter that replaces the scalpel. She asks if it's surgery. You say not exactly. She asks if it's radiology. You hesitate. The conversation ends when you tell her you'll have a job in 6 years. Your father asks how much it pays. You tell him you don't know yet. The country opened 207 integrated IR seats this year. You got 1. Most of your medical school class matched into something people recognize. Internal medicine, emergency medicine, family medicine. At the post-match dinner, classmates ask each other what they matched. When you say IR, 3 people in a row say, "Oh, like x-rays." You stop trying after the third. $300,000 in student loans. The repayment clock starts the moment you graduate. The first attending paycheck arrives in 7 years. You don't tell anyone how many years it will take. The night before residency starts, you stand in your apartment looking at the white coat you ordered. Long, not short. The short one was for medical school. The long one means you sign orders that get carried out without anyone checking. You hang it in the closet next to a stethoscope you almost never use, because the field you matched into doesn't need one. You don't know yet about the 3 a.m. call where you save a life alone and the medicine team takes the credit. The first month of your first attending job will not look like the residency that trained you for it. And the procedures you spent 14 years learning will be slowly taken from you by the specialty next door. You know one thing. Somewhere, right now, someone is saving a life with a 1 millimeter catheter. You want that to be you. Intern year starts in 8 weeks. Level 2, Intern. Your first year of residency is not interventional radiology. You spend it on a surgical service that is not your specialty. 3 months of trauma, 3 months of vascular surgery, 3 months of general surgery, 3 months of intensive care. The hospital pays you $72,000 to be the first responder on someone else's patients. Pre-rounds start before sunrise. Notes get written for patients who leave the floor before you remember their names. Potassium gets managed in the middle of the night. The stethoscope around your neck stays mostly cold. At 3 a.m. on a Tuesday in October, the trauma bay pages someone, IR. A blunt trauma patient is bleeding from a splenic laceration. The IR fellow you will become in 5 years shows up in a flannel shirt and unscrubbed scrubs. He sheaths the right groin in less than a minute. A wire runs up the aorta, and a microcatheter slides into the splenic artery. He throws coils until the angiogram run shows the contrast has stopped. The patient stabilizes on the table. The trauma surgeon thanks him by his last name only. The fellow signs his procedure note and is gone before morning rounds start. You watch from the doorway and write a consult note that says you called him. The trauma chief takes credit for the save at sign-out. In the call room at 4 a.m., you check your loan balance on your phone. You have spent the year wearing a stethoscope you don't need and watching someone else do the job you matched into. The thing you actually want to do is happening 1 floor away every night. You are not in the room. In November, a senior surgical attending asks why you matched IR. He tells you general surgery is the real lane. Real cases, real patients, real autonomy. You say you want image-guided procedures. He laughs and tells you IR is just plumbing for the rest of medicine. He has been an attending for 18 years. He has not watched anyone save a hemorrhaging patient with a coil in a decade. 12 months. Then you start radiology. Level 3, Diagnostic Radiology Resident. 3 years of diagnostic radiology before you can call yourself an interventionalist. This is the year you learn to read. 40 studies a day in your first month, then 60, then 100. CT abdomens, chest x-rays, mammograms, brain MRIs, ankle films, follow-up scans on patients whose names you will not learn. The screen runs 8 feet wide across your reading station. You sit on a chair for 10 hours and look at images. The senior attending in the room next to you has been reading for 22 years. He sees in 1 second what takes you 40 seconds. He moves through cases the way a fluent speaker moves through a language. You are still translating. In April of your second year, the Radiology Board Core exam, 18 image categories, 6 hours of test, 1 year of dedicated study, you resented every week. You pass. The piece of paper says you are board eligible. You go back to the reading room the next morning. Then in your third year of diagnostic training, you get your first rotation in IR. You scrub in for a tunneled central line on a chemotherapy patient. The attending lets you make the first incision. You are still wearing the resident's short white coat over the apron in the IR suite. The apron pulls down on your neck like a weighted vest. Your hands shake on the first pass. The attending puts his gloved hand over yours and guides the wire into the jugular vein. The patient is sedated and draped. The only thing he will remember is the soreness in his neck the next morning. On the third case of the rotation, the attending does not put his hand on your wrist. The wire goes into the vein on the first pass. He nods at the screen. You nod back. You finish the procedure at 8:40 a.m. By noon, you are back in the reading room. By 5, you have read 50 studies. By 8, you are home. In the spring of that same year, a co-resident leaves the program. He matched into integrated IR with you and washed out of the diagnostic radiology base. He takes a job at a tech company helping startups read scans with machine learning. He sends you a Slack message saying he is happier than he was last week. You do not message him back for 3 weeks. You finish diagnostic radiology. Your name is on the board certificate. The leaded glass window in the reading room is the closest you have come to a procedure all month. In July, you start your dedicated IR years. Level 4, Interventional Radiology Fellow. You are now in your dedicated IR years. The apron is heavy, 12 pounds across your shoulders, 8 hours a day, and it has started to leave a permanent ache in your lower back. The badge clipped to your collar tracks your radiation exposure. The number on it ticks up every shift. 3 a.m. The page is from the Medical Intensive Care Unit. A patient has been bleeding from a duodenal ulcer for 6 hours. The endoscopy team tried to clip the vessel twice and failed. The surgeon on call says he is not operating on a coagulopathic septic patient at 3 a.m. if there is another option. You are the other option. You have done this procedure as the operator exactly 6 times before. 3 of those were with the attending standing next to you, a gloved hand on your wrist. The other 3 were not embolizations. They were drainage catheters and a port placement. This is the first call where the operator is you and only you. You walk into the cath lab alone. The technician is waiting. The radiology resident assisting you is 2 years behind you in training. The attending is in the call room 3 doors away, sleeping. You sheath the right groin and wire up the aorta. The microcatheter goes into the gastroduodenal artery. A selective angiogram shows a pumping bleeder at the duodenal bulb. You drop in 3 coils. The repeat run shows no more contrast in the vessel. The patient's heart rate drops back into the 80s. In the cath lab afterward, the technician is putting away the equipment. He has been doing this for 15 years. He looks up at you and says, "Nice work." You stand at the screen for another minute and watch the last selective angiogram run on loop. The contrast stops at the duodenal bulb the way it is supposed to. You unscrub. The procedure note gets written. You go home in the dark. The next morning, the medicine team rounds on the save without you. The grand round slide for next month will say the medical intensive care unit saved a life on October the 14th. At 7:30 a.m., the attending reads your note. He signs off and emails you a single line. Nice case. The credit isn't yours. You tell yourself you don't need it. You have the 1 millimeter catheter. Level 5, junior attending. 8 years after starting medical school, you sign your first attending contract. The number on it is $651,000. You spent your residency in a clinical model program. You rounded on patients. A fibroid embolization clinic ran on Thursdays. Your own oncology patients came back to you through 3 rounds of chemoembolization. The modern IR specialty has been telling itself this clinical model is the future. The group that hires you is private practice. You start on a Monday in July. Your schedule for the first month, 18 paracenteses, 12 lumbar punctures, 6 arthrograms, 4 port placements, 3 thoracenteses. No embolizations, no ablations, no clinic. The embolizations and the ablations are on Tuesday. You are not on Tuesday. In your first week, you suggest opening a clinic for fibroid embolization referrals. The senior partner laughs. He tells you the OBGYNs in this city would never refer to your group. That lane is owned by vascular surgery. He moves on to discussing the reading room call schedule. In your second week, the practice manager hands you a stack of body CT studies. The group expects all attendings to clear 40 diagnostic studies a day between procedures. You ask if this is normal. She looks at you the way a person looks at someone who has not been told the rules. She says yes. You eat lunch at your desk reading abdominal CTs. The other partners eat in the doctor's lounge. In the procedure room, you tap the abdomen of a cirrhotic patient who has been on your list 4 weeks in a row. She asks if you are a surgeon. You say no, you are an interventional radiologist. She asks if that means you fix the X-ray machines when they break. You drain 6 liters of fluid out of her belly and send her home until next month. 6 months in, your first complicated case lands on the schedule. 47 years old, hepatocellular carcinoma, hepatitis B that nobody caught in time. The medical oncologist has referred her for radioembolization mapping, the first of 3 procedures that will extend her life. You do the mapping case yourself. The contrast tree fills out perfectly on the angiogram. Every segmental artery feeding the tumor is accounted for and ready for the 2 procedures that come next. You see her in the recovery bay afterward. She asks where she should send the thank you card. You tell her to send it to the office. She thanks the oncologist by name. The card she sends to the office does not arrive. You don't know yet that half your residency class will be looking for new jobs by the end of year 1. You start looking too. Level 6, partner. 12 years out of medical school. You have made partner. The W-2 last year cleared $780,000. This is the year you finally stop fighting the diagnostic burden. You read CT studies 3 afternoons a week. You do procedures on the other 2. Lunch in the doctor's lounge on a Tuesday. The new cardiology fellow introduces himself. He asks what you do. You say IR. He says, "Oh, the rads." A vascular surgeon at the table nods. You start to explain peripheral artery work, fibroid embolizations, port placements, biliary drains, oncology, stroke for the centers that have neuro-IR coverage. The fellow nods politely. He asks if you also read X-rays. You stop talking and chew your food. The next week, you find out the cardiology group has hired a second interventional cardiologist who will start doing peripheral artery cases. They have built a vascular access lab. The vascular surgeon's partner has expanded into uterine fibroid embolizations through a new women's health line. The OBGYNs in the city are sending fibroid patients to vascular surgery now, not to your office. A specialty fellowship was created during your residency for the procedures you trained for. The fellowship was given to another field. You did not stop being good at your job. The oncology work and the neuro work are still yours. The rest is being absorbed by neighbors who brought their own clinic infrastructure. Your case mix shifts toward the work nobody else wants: drains, gastrostomies, biopsies, long-term central access. The trash collection that ambushed you in year 1 comes for you again at year 12. This time, it does not leave. In the cath lab, your senior tech has been with you for 10 years. She knows your hands. Before you ask for a wire, it is already in her glove. On her side of the table, the work is still good. On a Wednesday in March, the office receptionist tells you the woman with the liver cancer called, the one from your first year. She has a new tumor in a different segment, and the oncologist has scheduled another embolization. The procedure was assigned to your partner because you are booked in the reading room that morning. She asked the receptionist if you could do it. The receptionist did not put her through. You do not return the call. You spend the afternoon reading abdominal CTs. In the cath lab at the end of one of these days, you finish an embolization on a different oncology patient. The 1 millimeter catheter is still in your hand when you sit down to write the note. It is the same tool you used in residency to save the GI bleed patient. It still feels right in your hand. You don't know yet that the senior partner you respect most is leaving the group in 8 months to open his own office-based lab. You will spend 3 weeks deciding whether to follow him. Level 7, Senior Attending, 20 years out of medical school. There are 2 paths to the ceiling. They cost different things. Path 1. You have neurointerventional training, 1 extra year of fellowship added to the 7 before it. You thread microcatheters into the first branch of the middle cerebral artery while a patient's brain dies in real time. 3 a.m. The stroke alert goes off on your hospital phone. Major stroke. A clot blocking the largest artery feeding the right side of the brain. You drive 12 minutes to the hospital. By 4 a.m., the clot is in a specimen cup. The patient will walk out of the hospital because of your hands. Half the country is more than an hour from anyone who can do this procedure. You drive home at 5 a.m., sleep until 7. There is a radioembolization mapping case for liver cancer at 8:30. You drink a third coffee. Path 2. Your office-based lab has been open for 2 years, 3 procedure suites, your name on the door, fibroid embolizations, and peripheral artery work on a schedule you set. No diagnostic reading, no partners pulling you back into the reading room. The build-out cost $3 million. The break-even point is 6 months from now. You took out a second mortgage on your house to make the lab possible. Either path, the W-2 clears $1 million. The stroke path costs sleep. Call comes every 4th week. Single coverage is the norm. When you are on, you are the entire stroke service for a 500,000 person catchment. Your back is permanently bad from 20 years in the cath lab. Your dosimetry badge total is one of the highest in the hospital. The OBL path costs the work itself. Mornings are procedures, afternoons go to lease negotiations, payroll, marketing, regulatory filings, and insurance contract calls. You signed up to be a doctor. The job has turned into running a small business with a procedure license. At a tumor board meeting on a Thursday, an oncology colleague reads aloud the names of every specialty on a patient's care team. Surgical oncology, medical oncology, radiation oncology, pathology, the nurse navigator. You recognize the patient on the slide. She was your first complicated case as an attending. The radioembolization mapping you did 7 years ago is the reason she is still alive at this meeting. Her disease has come back in 2 new segments. She does not have many months left. The presentation goes on for 40 minutes. Nobody mentions IR. 20 years out, end of a Thursday. You finish the last case of the day, a routine port placement on an oncology patient who reminds you of the first complicated case you took as an attending. The wire goes where you want it. The catheter slides home. The procedure takes 38 minutes. The chart will say everything except your name. In the cath lab, the apron comes off your shoulders. The dosimetry badge gets clipped to the rack. The technician asks if you want coffee for the road. You say no. You drive home with the windows down. More and more of the work you spent 14 years learning is now done by other specialties. Most of the patients you saved this year do not know your name. The catheter is in your hand. It has been for 20 years. Tomorrow at 6 a.m., you will be back in the cath lab. The senior tech locks the cabinet behind you and calls you good night by your first name. After 10 years, she has never called you anything else. You wouldn't trade it.